Greeting and welcome to today's webinar titled A Joint Venture for Defeating Infectious Threats Post-Transplantations, Pathologists and Microbiologists Together. My name is Dr. Oksana Volod, and together with Dr. Christine Kowal, I will be co-chairing this webinar. I'm clinical pathologist, director of coagulation consultative services, and professor in the Department of Pathology at Cedars-Sinai and UCLA. I work closely with MCS team to manage patients' anticoagulation and coagulopathies. Dr. Christine Kowal is the transplant infectious disease section head at the Cleveland Clinic in Cleveland, Ohio, associate professor of medicine, Cleveland Clinic Lerner College of Medicine, and Case Western Reserve University. Her particular interest is infections in solid organs transplant recipients and infections in immunocompromised hosts. As you know, heart and lung transplant recipients are highly susceptible to conventional and opportunistic infections, which represent a major cause of morbidity, graft dysfunction, and mortality. During this webinar, which was a joint effort of expert speakers and junior colleagues, newer and current diagnostic approaches to identify transplant-related pathogens will be discussed. This will be followed by the relevant to heart and lung transplant recipients cases presentations and discussion. Panel discussion with question and answer will be at the end of the session. Please post your questions through the chat. We're going to start with the first part of our webinar, which is Introduction to Laboratory Medicine and Pathology Methods to Diagnose Transplant Recipients' Infections. It is my pleasure to present Dr. Margie Morgan, who is the Medical Director of Microbiology and a professor in the Department of the Pathology and Laboratory Medicine at Cedars-Sinai Medical Center. She obtained her PhD in microbiology and immunology at the University of Oklahoma and fellowship in clinical microbiology at Mayo Clinic. Dr. Morgan is board certified through the American Board of Medical Microbiology. She is the founding member of the Cedars-Sinai Antimicrobial Stewardship Committee and is involved in hospital epidemiology, surveillance, operations, and investigations. And she is also director of diagnostic infectious disease testing for the Special Pathogens Laboratory Unit. She has over 100 abstracts and publications with a major research interest in improving antimicrobial stewardship and advancement in diagnostic technologies. On a personal note, she is a wonderful colleague, mentor, and a teacher. Dr. Morgan, thank you, and please start your talk.
Thank you so much for that very, very kind introduction. And today, as Oksana says, I'm going to talk about microbiology's role in diagnosing transplant infections. First off, what are we primarily looking for? Well, this is the list of the most common infections that we see, particularly in lung transplant patients. So you can see that microbiology can truly play a role if those are the primary things that we're looking for. So what kind of methods would we use to search out these organisms? Well, to be able to adequately do cultures, we're going to need to do, and molecular testing, we're going to need correct specimen collection and processing. And this is very, very important for microbiology, but a little bit out of our hands. We need an adequate volume of specimens sent to us. We want it to be prior to antimicrobial therapy. And the specimen should be unopened prior to delivery to microbiology, or we might have issues with contamination. We can do a variety of different specimens, such as tissues, sterile body fluids, CSFs, and blood culture. I've listed some of the demands, and I guess we are a little bit demanding, but we're just trying to do the best job. So we like to have adequate sizes of tissue to be able to culture. One of the things that kind of borderline drives us crazy is tiny little needle biopsies floating in liquid, and we can barely find the sample. Sometimes we don't feel that that would be an adequate specimen for us to do good culture. Sterile body fluids can be submitted either in blood culture bottles or more than 5 mils of specimen. This is dependent upon your own hospital, whether they use blood culture bottle collection or they prefer to do agar culture. CSFs. As time has gone on, we've needed more CSF specimen in microbiology. Oftentimes, they're not satisfied with just culture procedures. They want to do extended testing. So please send us greater than 3 mils of CSF. And blood cultures. They should always be collected in a very sterile fashion with adequate volume. and at least 2 sets of blood cultures should be collected. If we have all that in place, we're going to do cultures for you, and we can do bacterial, fungal, and mycobacterial cultures. What's the advantage of microbiology cultures? Well, we can do very rapid detection and identification of most bacterial species and yeast. MALDI-TOF has greatly advanced identification, made it far more extensive for the organisms that we can identify, and far more rapid. It's much better than the older biochemical characterizations. Also, the advantage of doing cultures is we have the organism available if we want to do susceptibility testing and further studies. But it's not all perfect. Cultures do have a few disadvantages. Of course, some very important infectious agents are not culturable. If the patient's been on previous antibiotics, we may not be able to culture anything. And sometimes we're not very fast, or as fast as you would like us to be. Some of the select molds and mycobacterial species can take greater than 10 days to grow. Also, if you're expecting something unusual, talk to your microbiology laboratory. There might be something special that we can offer or do to help in our cultures. But much has been moved on from culture to using molecular methods as well. There's rapid and sensitive PCR tests for diagnosis for many pathogens. And of course, it has become the gold standard for the detection of viruses. It is also very helpful for organisms that grow slowly, such as Mycobacterium tuberculosis, or those that are not culturable at all, such as Pneumocystis. There are many commercially available tests that your laboratories are able to purchase for the molecular detection of select pathogens, but not all are available. Some laboratories may have developed laboratory-developed tests, or they may be dependent upon sending out to a reference laboratory for such testing. And you need to discuss it with your laboratory about what tests need to be sent out. There are very good syndrome-based multiplex PCR panels that are quite available to clinical microbiology laboratories. These are based on patient syndromes, such as a respiratory syndrome or GI syndrome, and they will test for infectious organisms particularly associated with that syndrome. These panels will include both bacterial and viral targets. There's many available that laboratories can purchase, and they are multiplex panels that will diagnose a variety of syndromes such as sepsis, respiratory pathogens, enteric stool pathogens, and encephalitis and meningitis. This is just an example of one type of multiplex PCR panel that's available on the market. Some of these are expansive with numerous bacterial and viral targets. They can also contain antibiotic resistance markers, and these are best used for the particular kinds of patients that we're talking about today, the very ill, compromised patients that have had transplants. These panels can be expensive and they will not be used possibly across the board, but they can be used for select patients when they would be serve this patient population. But there's other very creative and newer things also being offered. They may not be offered in your routine clinical microbiology laboratories, but more in specialized labs or reference laboratories. They can detect and identify bacteria from normal sterile sources, a variety of different kinds of body fluids, and even formalin-fixed paraffin-embedded tissues. This test is optimal for situations in which bacteria are visualized in the specimen, but in the microbiology laboratory, we fail to grow anything and have not yielded a diagnosis. When doing broad-range bacterial PCR and sequencing, if the PCR test is negative, no sequencing is performed, and the test will be resulted as negative. However, if the PCR test is found to be positive, they will then do next-generation sequencing with target metagenomic testing to provide extremely comprehensive information on the gene content, and this will provide identification information as well. Other things which are available to our infectious disease and medical personnel to order are liquid biopsies. This is when you actually just collect a 5 ml sample of EDTA blood, and they can send it to a specialized reference laboratory, and they can do specimen processing that includes DNA extraction and library preparation. They will sequence it and then analyze the specimen and report the results. This kind of testing has been useful in culture-negative endocarditis, febrile neutropenia, especially in cases of fever of unknown origin, and possibly in invasive fungal infections and respiratory infections, where unfortunately microbiology culture has not been helpful. The other thing that's going to be available in the future, and is still and may be available in some very specialized hospital laboratories, but mostly for research purposes these days, is mass spec and proteomics. Proteomics can be used to detect biomarkers of infectious diseases. It can detect pathogen-derived proteins or peptides from body fluids and can be used as a diagnostic tool for identifying infectious diseases. These programs are still the future for most microbiology or clinical laboratories because they have some technical difficulties, particularly in the interpretation of the library generation workflows. They can be very difficult to interpret. But this is something that we look toward for the future, and it could be particularly helpful for the diagnosis of unusual infections. So how do we put all this together? Well, the way I view this is we're going to start off with doing culture because I'm a microbiologist. So I hope that cultures are ordered for bacteria, fungal, and mycobacteria. There can also be select PCR assays that are ordered up front as well. As time moves on, we're going to review and compare this to anatomic pathology tissue findings, and perhaps at this point, arrive at a diagnosis. If a diagnosis has not been obtained, that is when you need to acquire more information, and you're going to reach out to the specialty laboratories that offer a broad range PCR, liquid biopsy, and such. And with those words, I close. I thank you, and we'll go on to the next speaker. Thank you.
Thank you, Dr. Morgan. Our next speaker is Dr. David Huang. He is a thoracic pathologist and chief of the Department of Laboratory Medicine and Molecular Diagnostics at Sunnybrook Health Sciences Center in Toronto. He has longstanding clinical and research interests in lung transplantation as a member of the Toronto Lung Transplant Program, and was part of the team that described and defined restrictive allograft syndrome. Welcome, Dr. Huang.
Thanks very much, and thanks to the organizers of this webinar for inviting me to speak to pathology and pathology techniques in the diagnosis of transplant infections. So when we think about pathology in transplant recipients, there are a number of specimens that we may receive in pathology, most frequently biopsy or I guess pieces of tissue for histology. So in the heart, these may be endomyocardial biopsies, in the lungs, transbronchial biopsies, occasionally wedge biopsies, and very occasionally whole explanted retransplant lungs, and also occasionally biopsies from other body sites, for instance, if there's an abscess or a tumor somewhere. Cytologic specimens, primarily in lung transplant patients, BAL fluid, brushings, washings, fine needle aspirates occasionally, and then, of course, the occasional postmortem examination. When we think about the role of pathology in lung transplant or heart transplant recipients, biopsies in these patients are most often done for our surveillance or diagnosis of rejection. And so when you think about the specimen or sampling requirements of pathology biopsy specimens, typically these are geared primarily towards diagnosis of rejection. And only secondarily is pathology typically used for identification of other processes that may impact on graft function or patient outcomes, one of which, for example, would be infections, but also things like recurrent native disease. So here we've got a picture of pulmonary alveolar proteinosis, which may recur in the transplanted lungs. occasionally malignancy, things like PTLD or other malignancies. And then for lung transplant recipients, aspiration. So we've got some vegetable material here in this transbronchial biopsy with some surrounding inflammation. When we think about pathology techniques in diagnosis of infections, it's important to remember that these biopsy specimens that we see in pathology typically are formalin fixed and paraffin embedded, or FFPE material. And this is really optimized for examination of the histomorphologic features of the tissue and for certain downstream ancillary stains. So typically for histomorphology, this would be H&E. May not be really the best way to look for infectious organisms. So there are a number of special stains that could be done. Just to list a few here, methenamine silver stains, such as GMS staining, are often used for fungi. In general, I think in the lungs and I assume in the heart as well, a silver stain, in my experience, is better than a PAS or PASD stain for the most part, although sometimes I guess people like the PAS stains. Gram stain for bacteria and ZN for mycobacteria. And then there are a range of other stains that could also be done, but typically are done less frequently. And then immunohistochemical stains for specific infections can be used sometimes. For example, CMV, HSV, Legionella. I believe there's immuno even for COVID-19, but there's a whole host of immuno that your lab may or may not have. When we think about FFPE biopsy material, these are not suitable for culture-based microbiology testing. So if culture-based microbiology testing is desired, as it usually is, there needs to be either fresh tissue or fluid specimens such as BAL that's submitted, and Dr. Morgan reviewed the requirements for those sorts of specimens. That having been said, FFPE material may be used to extract nucleic acids for molecular tests, and the whole range of testing from single organism tests to multiplex panels to metagenomic, whether it's sort of targeted or even sort of whole metagenome sequencing, can be done on DNA and RNA from FFPE specimens. A number of pitfalls and things to keep in mind, though, if you are going to be doing molecular testing on FFPE. Really special precautions do need to be taken to reduce the risk of cross-contamination between specimens. This sort of cross-contamination most frequently would be from carryover between cases on the same microtome. So for instance, the microtomes would need to be thoroughly cleaned, the blades would need to be changed, even the water bath that's used to float the tissue specimens needs to be changed and cleaned between specimens. So these are things that really need to be kept in mind. You don't want, for example, to have a previous case of TB or something that's cut on the same microtome as the next case that you're sort of looking at transplant molecular for. False positive results certainly can happen, most frequently due to carryover, but other causes as well. So proper controls would be needed. And bearing in mind that most anatomic pathology labs wouldn't be kind of doing their own microbiology molecular lab tests, these would typically go to the microbiology molecular labs. It's important to bear in mind that these lab tests may not actually be validated for FFPE material. So that's something that needs to be worked out with your microbiology and or molecular colleagues. Now, overall, when we think about the role of pathology diagnosis in infections in transplant recipients, this is one of the few times that you'll hear me as a pathologist say that we're kind of secondary. I wouldn't say that we're superfluous, but our role is generally to corroborate microbiology findings. So in general, for example, to identify histologic findings that support a diagnosis of infection, such as acute or chronic inflammation, granulomas, acute lung injury, viral cytopathic effects. And bearing in mind that the histologic features of infection may often show significant overlap with features of other processes such as rejection or aspiration. So that's why correlation with microbiology is just so important. Very occasionally, pathology may actually be the first to either site suggest or identify specimens, even before microbiology does. In general, I've found that if I've identified an infection, look in the clinical record, it's like, darn, those microbiologists got to it before I did. But very occasionally for things like fungi or mycobacteria, the very occasional or rare nocardia infection, we may actually see it in our histologic sections before the microbiology results are available. And that depends on your lab procedures and turnaround times. But even in these situations, most of the time, microbiology correlation will still be needed. Okay, so I think that's it for my presentation, and I'll pass it on to the next speaker.
Thank you, Dr. Wong and Dr. Morgan, for very brief but comprehensive information. And for the audience, please do not forget to post your questions into the chat, and which we will go through at the end of the all talks. And we're going to move to the next section of our webinar, which is entitled When Pathologist Needs the Microbiologist to Reach the Final Diagnosis, the Contribution of the Microbiologist to the Final Diagnosis. And I'm going to present our next speaker, Dr. Sharon Leung. Dr. Sharon Leung is a staff specialist in anatomic pathology at St. Vincent's Hospital, SIDPATH in Sydney, Australia. While she covers a broad area in anatomical pathology, she has a special interest in cardiovascular pathology. In addition to her clinical work, Sharon is passionate about teaching and education. She actively participates in the education of medical students and serves as a conjoint lecturer with the University of New South Wales. And today she will be sharing an interesting case on the heart pathology. Welcome, Sharon.
Thank you. Thank you for that. Hello to everyone tuning in. My name's Sharon, and today we're presenting a very interesting case that actually was an autopsy case for us, which was unfortunate, but it yielded some very interesting results. So the case is of, oh, sorry, suddenly my screen, oh, there we go. Is of a 24-year-old female who was actually 2 weeks postpartum, who presented with progressive shortness of breath, postural dizziness, vomiting, and lethargy. She had a significant medical background for a cardiac transplant 3 years prior for congenital complex heart disease. Since her transplant 3 years prior, she'd actually had recurrent rejection episodes since. Her most recent rejection episode was actually only 2 weeks following the delivery of her son, where she had cardiac graft dysfunction and anuric renal failure from cardiorenal syndrome. And at that time, she was treated for both cellular and antibody-mediated rejection, and she had recovered. She then unfortunately declined again. And when she presented, she was admitted initially to our rural hospital, and the clinical impression then was that she was having another episode of rejection with fluid overload and a decline in systolic function. Her ejection fraction at the time was 30%. She was commenced on continuous renal replacement for fluid removal, low-dose dobutamine, as well as IV methylpred. She was then subsequently transferred over to us for ongoing management. When she arrived, we did a repeat TTE, and her ejection fraction continued to decline. So it went from 30% to 15%. She was at that time offered an EMBX. Unfortunately, she declined it, and she had quite severe needle phobia. Her admission was then quite stormy, and it was quite complicated. She had cesarean wound site breakdown, progressive renal failure, progressive liver dysfunction, and this ongoing cardiac graft dysfunction, despite very aggressive treatment for rejection. She then suffered a cardiac arrest in ICU, and she passed away 3 weeks into her admission. Her family then consented for a post-mortem. And the post-mortem findings, just concentrating on the cardiovascular system, the heart was a little bit heavy, 598 grams. And you can see actually the cut sections from the base to the apex. There was no obvious gross lesions to be identified. If anything, just the general cardiac muscle looked a bit mottled in areas. And there were these very vague, sort of slightly more pale areas, which didn't look that obvious, but we sampled these areas just in case. And we were quite surprised to see the histological findings. So in the right ventricle, and you can see it here, the low power, there's just that area of purple area that was actually suppurative inflammation, lots of neutrophils, and you can see the neutrophils surrounding and infiltrating the cardiac myocytes. You couldn't see it on the H&E, but we did a methionine silver, and you can see it quite clearly here. We've got lots and lots of these fungal hyphae just infiltrating into the myocardium. In the lung as well, we found the same fungal organisms, and on this picture here, you can see that there's a vessel wall here, and within it, lots of fungal hyphae. And again, that's on the H&E, but the methionine silver again highlights that quite nicely. We sent away this tissue block for a pan-fungal PCR to our reference hospital, and it was actually positive for this fungus Scedosporium apiospermum, which I personally had not heard of, so I was very interested. The background myocardium showed some features of a mild acute cellular rejection, ISHLT grade 1B1R. And so in conclusion, the cause of death was attributed to cardiac failure, secondary to a combination of this angioinvasive fungal infection seen in the right ventricle of the heart and the right lung, as well as a mild acute cellular rejection. This is in the setting of immunosuppression for cardiac transplant and a recent pregnancy. And so that concludes the case study. I hope you found it as interesting as I did. Thank you.
Thank you, Dr. Liang, for really very interesting but with sad outcome case. And we're going to continue this mode to the discussion by Dr. Tina Martinelli also on the heart subjects. Dr. Tina Martinelli is a general and transplant infectious disease physician at the Royal Prince Alfred Hospital and a senior lecturer at the University of Sydney. After attaining her FRACP in adult infectious disease, she completed a 2-year clinical and research fellowship in transplant infectious disease at Toronto General Hospital, and subsequently an editorial fellowship with American Journal of Transplantation. And welcome, Dr. Marinelli, for your discussion.
Thank you. Thanks for the invitation and for the very interesting case to discuss. So these are my disclosures. So I'm starting off just talking a little bit about invasive fungal infections in solid organ transplant recipients. And this first graph is a very nice demonstration that's taken from the Swiss transplant cohort study, where they looked at all of infections from their cohort over a number of years. The first bar here is this is all fungal infections, and the first bar here is heart transplant recipients, and it's showing the sites that are most commonly infected with fungal organisms. As you can see, the most common site is the respiratory tract, as we would expect, given that we're always breathing in fungal pathogens, followed very closely by mucocutaneous and blood down here in the red. Now, when we look at what these fungi are, this is some data taken from a Transnet study, which is old now. It's about 2 decades old, but it stands when it's repeated. The incidence of fungal infections is fairly consistent. So in heart transplant recipients, the number one fungal infections is candidiasis, candida infections, which usually occur early post-transplant, followed by aspergillus. Scedosporium would fit into the other mold category, and they're actually relatively rare in all transplant recipients. This is from an article Jay Fishman wrote in Transplantation, looking at the timing of invasive fungal infections in solid organ transplant recipients, and this fits quite well with heart transplant, in that in the early post-transplant period, we're really looking at healthcare associated infections, and we particularly see candida infections over that time. We also see donor-derived infections occur during that period, they're far less common in heart transplant when you compare, for example, to lung transplant, where the donor lungs may be bringing along a fungus with them. As you get to the 1 to 12 months post-transplant, we start to see more environmental type things like aspergillus in particular. Mucor and Scedosporium fall into this, and your endemic fungi. PJP starts to occur a little bit later post-transplant, depending on whether someone's on prophylaxis or not. most lung and heart transplant recipients in most centres will continue lifelong PJP prophylaxis. However, it's sometimes stopped because of side effects or other reasons. And when we're looking to more than 12 months post-transplant, it's really a community-acquired environmental type pathogens. So Aspergillus, again, very common in our environment, Cryptococcus neoformans, depending on where you are in the world, and then Mucor and Scedosporium as well occurring in these places. And at this time, most people will have stopped any sort of antifungal prophylaxis that they had around the time of transplant if it was given by that centre. So in heart transplant recipients, having a quick look at when invasive fungal infections occur, most, as I mentioned, occur in the very early post-transplant period within the first 3 months, involves the lungs and the surgical site, and these tend to be your candida infections. Risk factors that have been identified in a study by Zachary Yetmar include additional induction immunosuppression, allograft rejection, and of course treatment for that, reoperation within 10 days of transplant surgery, delayed chest closure, a peri-transplant ventricular assist device, and renal replacement therapy. And this is important because invasive fungal infections are associated with increased mortality quite significantly. So moving on to discussing the Scedosporium species. So they're soil saprophytes, and so they're really, really hardy organisms. They grow in the environment. They're tolerant of all sorts of temperature rate fluctuations. They can grow in low osmotic pressure environments and high salt environments, and in places where there's not a lot of oxygen. So they really thrive in soil. They're particularly distributed in temperate climates rather than the tropics. So we see a lot of Scedosporium in Australia, and there's quite a lot in Europe also. Interestingly, Scedosporium, the ecology of it is really strongly impacted by human activities. There's a really high occurrence in water and contaminated water and in very highly polluted soil because the fungus can use certain nitrites from various substances in order to grow. So it's unlike Aspergillus, which we often see in construction sites, for example, in hospitals that are having construction, we often see outbreaks of Aspergillus. Scedosporium isn't usually isolated from the indoor environment. However, if we have things like plants in the environment, that does increase the risk of Scedosporium being there. There was a very nice study done in the homes of cystic fibrosis patients where they were swabbing various aspects of the home to see where fungus was. And indoor pot plants were very strongly associated with the isolation of Scedosporium species. So out of this group, the principal human pathogens are Scedosporium apiospermum, Boydii, and Auranticum. Lamentispora prolificans used to be called Scedosporium prolificans, but it was renamed a number of years ago because it is actually very phylogenetically and morphologically distinct. And as you can see here on the dendrogram, the top colours here, they're all the Scedosporium species, and Lamentispora is in the green at the bottom. You can see phylogenetically it diverges quite early. So it is a very different pathogen, and it's very different in its clinical presentation and susceptibility testing. So going a little bit further into Scedosporium, as I mentioned, mainly abundant in Australia, lots of reports from France, the Netherlands, Morocco, Thailand, and Mexico. The colonies, it does grow very well. Optimal growth is 37 to 40 degrees, but it can grow outside of those temperatures, and it's usually fairly easy to isolate in the microbiology laboratory within 2 to 10 days of the cultures being set up. It's got cylindrical, slightly flower-shaped conidia that arise from undifferentiated hyphae, but on a histopathology slide, you really wouldn't be able to determine which species is which, and even determining Scedosporium. We really need more advanced techniques, even in the microbiology lab, even with the slides, to be able to identify it. If we don't have a even sometimes with culture, sometimes you can't identify it. So we'd two things that are used very regularly to identify Scedosporium species are ITS sequencing, which is the internal transcribed sequence, or MALDI-TOF more commonly, if the microlaboratory has a library set up to analyze fungi, they can quite readily look at it with the MALDI-TOF. Just looking at Scedosporium apiospermum, out of the Scedosporium species, it's probably a better one to have in that it's usually more susceptible to antifungals, particularly voriconazole would be our first-line agent. Posaconazole and itraconazole is also usually susceptible to. Isavuconazole and amphotericin have higher MICs, so they're usually not first-line agents for this fungus. And I'd like to again thank you for having me and pass on to the next speaker.
Great, thank you. I'm noticing a robust discussion happening in the chat. We will try to pull out some of those salient questions for discussion as we move through the conference. So now we're going to focus on how the microbiologist might need the pathologist to reach a final diagnosis. And our next speaker is Dr. Justin Burke. He is a rising third-year pathology resident at Washington University in St. Louis. After obtaining his Bachelor of Science from the University of Pittsburgh, he earned his medical degree from the Lake Erie College of Osteopathic Medicine in Erie, Pennsylvania, and his clinical interests include cardiothoracic and cytopathology.
All right, thank you very much for the introduction. We're going to go ahead and get started. So, I'm going to start off with our patient was a 65-year-old man who underwent bilateral lung transplantation for end-stage usual interstitial pneumonia. His 1-month follow-up biopsy, pictured here, showed no evidence of rejection. His post-operative course was complicated by several infections detected by bronchoalveolar lavage and in his blood. Notably, he had Klebsiella and Proteus species, Burkholderia species, multiple fungal organisms all detected on BAL, and he had CMV viremia detected not long after his transplant. 2 months post-transplant, he tested positive for SARS-CoV-2, although he was asymptomatic at that time. 4 months post-transplant, he was admitted to the hospital with several days of cough and fever. Bronchial lavage on admission was positive for SARS-CoV-2 and negative for CMV. On admission, a CT scan showed diffuse confluent ground glass opacification throughout both of his lungs, and he was treated for several weeks. However, he showed minimal improvement over that time. His follow-up BALs, he had one a couple of weeks later that was SARS-CoV-2 negative, and then one a few days after that was SARS-CoV-2 positive again. And later on in his admission, his CMV became positive on BAL. Later on in his admission, he started developing signs of sepsis, and a blood culture was positive for Pseudomonas aeruginosa, and a follow-up CT at that time showed that his ground glass opacities had resolved. However, they were replaced by fibrosis. So here we can see a comparison of his CT on admission to his CT towards the end of his hospital course. On admission, you can see the diffuse confluent ground glass opacity throughout this left lung, as opposed to several weeks later where the ground glass is gone. However, we have this dense fibrosis involving the lung instead. So he continued to decline, showed worsening shock with multi-organ failure, and ultimately did expire. An autopsy was performed, and the clinical question to be answered was rejection versus infection. Here's a representative image of his lungs. Section showed us this fibrotic phase diffuse alveolar damage picture with extensive structural remodeling with fibrosis, collagen deposition throughout the lungs. There was scattered chronic inflammation throughout. However, this wasn't really a prominent feature of his lung injury. On higher power, we could see some reactive cytologic atypia. However, there was no viral cytopathic effect to make us think CMV, so this is more consistent with a type 2 pneumocyte hyperplasia, which fits with his diffuse alveolar damage picture. And then we also had these areas of interspersed, relatively preserved lung with pulmonary and interstitial edema and no notable acute or chronic inflammation. So all in all, these features are more consistent with a chronic infectious process as opposed to allograft rejection. And his final cause of death was hypoxic respiratory failure secondary to COVID-19 pneumonia in the setting of Pseudomonas aeruginosa bacteremia. And with that, it's the end of my presentation. I'd like to say thank you and throw it to our next speaker.
Great, thank you. So our discussant for this case is Dr. Chae-Yu Lin. Dr. Lin is an associate professor and autopsy service director at the Washington University in St. Louis, Department of Pathology and Immunology. She graduated from National Taiwan University and completed her PhD and medical training at Stanford University. Her research focuses on cardiac allograft pathology, sarcoidosis, and myocarditis. Currently, she's active in the ISHLT membership committee and chairs the education committee for the Society of Cardiovascular Pathology. Thank you for joining us.
Thank you for the kind introduction. I would like to share some of the thoughts in a little bit discussion about this topic, how we work together between pathologists and microbiologists to support our lung transplant patients. So it's always a balance between infection and rejection. That's kind of almost like a holy grail questions we encounter every day as a team. And then these two significant morbidity for transplant patient can have overlapping clinical manifestation, imaging finding, and pathology finding. Particularly for lung transplants, the infection can come with various sources. It could be donor-derived, that donor-transmissible, like CMV and EBV. It could be the new infection that the patient unfortunately acquired either in the hospital setting or in community setting. It could be also a reactivation from patients, the recipients like latent infection, like HSV, VZV, or histoplasmosis. And we as a team, the ultimate goal is to prolong the graft survival and of course, ultimately the patient survival. Particularly for lung transplant, this is like too much to cover in the 10 minutes discussion. I'll try to keep it brief, but just like big categories, bacteria, viruses, fungus, and very rarely protozoa. Today, I'm going to focus on most of the discussion in the virus and kind of like a continuous discussion from the case that Justin just described. Some of the most common one, including CMV, EBV, and as I mentioned, HSV, VZV, and then a whole array of mostly community-acquired viral infections that Morgan just showed in, doesn't Morgan show in the panels, that PCR panel, like, RSV, influenza, parainfluenza, rhinovirus, just to name a few. And of course, in the past few years, we encountered new entities such as SARS-CoV-2 or COVID-19 infections. Fungal infection is also a common visitor in our service on lung transplant. A lot of time, it's very critical but difficult to distinguish between the colonizations of the fungal element versus true tissue invasions. Here again, some of the common player in this field is Aspergillus, Candida, Cryptococcus, and nowadays because of the effective prophylaxis treatments, we rarely see PJP or the old name PCP infections anymore. In 2010, when ISHLT put out the standardization of definition for infections for cardiothoracic transplant, it is very clear from the guideline that histology examination is an integrated part for infectious workup to help us to make the diagnosis and the classification of the infectious process for our transplant patients. So how can pathologists help? Here it's my, thought and experience. First and foremost, it is very important to confirm the end organ damage versus colonizations. For instance, PCR positive aspergillus from BAL or bronchial wash, it could be either colonization or invasive pulmonary aspergillosis. And then the biopsy or tissue sampling can help to make the distinguish between a true end organ damage versus colonizations. The other utility for pathology is actually to identify microorganisms that are not routinely tested for BAL microbiology panel. For instance, in our institute, HSV is actually not part of the routine BAL panel for either transplant or native patient, native lung BAL bronchial wash. And here's a nice HSV bronchitis that show the distinct viral cytopathic change, and later on we use IHC to confirm the diagnosis of HSV bronchitis. That was not obvious from the microbiologist standpoint, just because it was not part of the routine panel. And as David and others just mentioned, that is also very important to exclude a concurrent rejection because they do have overlapping features clinically. it's not always this straightforward and easy. They do have some unique challenging for us as pathologists to read allograft biopsies. First and foremost is that there are overlapping histological features between infection and or infection, recurrent disease, or rejections. Just to name a few. For instance, when we see an organizing lung injury under the microscope, it could be part of a non-specific antibody-mediated rejection process for the lung allograft, or is this a active or subacute infectious process? Or if you see a single granuloma or a scattered like small tiny naked granuloma in your lung allograft biopsies, and this patient was transplanted for pulmonary sarcoidosis, then are these granuloma represent reactivations or recurrence of pulmonary sarcoidosis, or it's infection, or it actually can be also aspirations? These patients are immunocompromised or immunosuppressed due to the transplant, so the tissue response can be more subtle compared to native lung biopsy. So we need to keep our eye out to see all the clues that we can find under the microscopy. And last but not least, we are subject to sampling. There are small pieces of biopsy tissue from bilateral lung. So even if there is a truly invasive process, invasive aspergillosis process or organ damage going on, we may or may not be able to see those under our microscope. So it is truly a multidisciplinary approach that we need to take care of these patient populations. CMV is the most common viral infections for lung transplant recipient, and nowadays we have well-established prophylaxis protocols and serology monitor to help us to treat these patients. However, a positive PCR result from blood or BAL do not necessarily correlate with the symptom or tissue invasive disease, because these patients may have a prolonged CMV viremia, but not necessarily have CMV pneumonitis. And BAL, although it's from the end organ tissue, which in this case lung, it's known that the patient can have a prolonged like pulmonary shedding that have the virus being detected in BAL, but not necessarily have the CMV pneumonitis. Therefore, biopsy is very specific, but of course it's less sensitive. The aim for us as a pathologist is to identify and confirm the organ damage and then make the diagnosis of CMV pneumonitis. Here's the pictures of one of my cases of the CMV pneumonitis from the lung transplant patients, that you can see that the background show organizing pneumonia, widened interstitial septa with mixed inflammations, and then a little bit, it's more like in the organizing phase of the acute lung injury. And here you can see a viral cytopathic change that later on we confirmed with the CMV IHC for the diagnosis. So again, like this kind of like CMV pneumonitis can have from acute to organizing lung injury pattern, and then up to half of the cases actually can have perivascular lymphocytic infiltrates. That may be difficult to discerning between A1 or A2 rejection versus CMV infection. If we're lucky, then we'll have the viral cytopathic change and also can be confirmed by the IHC. Other viruses that can be detected in the lung transplant biopsy and BL, including the influenza, parainfluenza, RSV, so forth and so forth. Usually, the histological feature for these community-acquired viral infection are variable and non-specific. And then sometimes you can see this kind of like type 2 pneumocyte reactive or hyperplastic change, and it could be difficult to determine whether it's a truly viral cytopathic change or just a metaplastic change. And from a practical perspective, I want to make sure that we exclude the CMV, adenovirus, HSV, and then to make sure that it's concordant with the BL PCR result. Just a very, very quick note that although technically this is a malignancy, but it is also due to the infection from after transplant is the EBV infections. And as we all know, that EBV infection can be associated with PTLD, post-transplant lymphoproliferative disorder. And the transbronchial biopsy may be prudent to make the diagnosis and to grade the PTLD. And here you can see the EBR highlights the positive cell, and this patient have a diffuse sheet of atypical B cells in the transbronchial biopsies. In the past few years, we encountered more and more different novel infectious entities, and one of them is the SARS-CoV-2 and COVID-19. And the positive rate of SARS-CoV-2 in lung transplant patients is actually if you read the literature and in your own institute, the rate count varies based on your institutional practice, based on whether in your institute do surveillance biopsy, whether they routinely do BL testing for SARS-CoV-2. And then it is also known for both transplant patient and non-transplant patients that the patient can have positive PCR result for months after the initial diagnosis, and it may or may not associate with the symptom. In our own cohort, we found that there are variable histological finding associated with a positive SARS-CoV-2 BL PCR testing at the time of a surveillance biopsy, although from unremarkable to organizing pneumonia, and the patient's outcome also is variable. And just as the non-transplant patient, fibrosis can be prominent in the later phase of the COVID-19 infection. So back to the case, this is unfortunately also an autopsy case, and during that 6 weeks of admissions, there wasn't tissue sampling, but you can see that there are multiple rounds of BL sampling, have variable CMV and then the COVID-19 PCR results. From extensive sampling from the autopsy, we do not see any viral cytopathic change to suggest CMV. The overall picture fits better with COVID-19 pneumonia with extensive fibrosis. We also do not see evidence of acute rejection, although the patient was empirically treated for that. So you can argue that maybe the histological finding is no longer there. So the question is that, would it help? Would it help that if we did the transbronchial biopsy throughout that 6 weeks of admission? Personally, I think it may or may not. And that's another reason I want, Justin and I would present this case, because diagnosing infectious process and then support lung transplant allograft lung transplant patient is a very challenging task that truly require a multidisciplinary approach. That I just kind of echo what David just said. I wish I can say pathology is the best, but it's actually truly a multidisciplinary approach that we need to do it together. So just kind of summarize that this short presentation is how can pathology help for this patient population is to have confirmed the end organ damage, to identify microorganisms that might not be in your routine microbiology panel, and to exclude concurrent rejections. Here is the list of the references for this talk, and I really appreciate this chance to share some of our thoughts in this interesting case with you all. Thank you.
Great, thank you all. I think you've highlighted again that transplantation is a team sport. And we're not even including the surgeons in this talk. So we know that, we need to be communicating with each other. But in the chat, I'm noticing that there's a few common themes. One is how to make some of the newer technologies more streamlined in the evaluation of these patients when the standard methodologies may not be as rapid as we want them to be. For example, a simple, quote unquote, simple question was regarding how to manage specimens when antibiotics have already been started. And those types of situations are common, and it may limit our yield on microbiologic results. So this was for Dr. Morgan, how to, sort of optimize our evaluation process using the available tools when it may not be the first test that would ordinarily be in line with our standard evaluation.
Yeah, that's a very difficult question, and I think different institutions may handle it differently. A lot of the more advanced tests and specialized tests that can assist in such situations can be quite costly, and you need to send them to specialized laboratories to be able to have them performed. So I think we usually have a discussion with the infectious disease people. We're very fortunate that our group is very knowledgeable about such things, and we'll talk about the best possibilities and what is most available to us. And oftentimes we do send out many things, particularly paraffin embedded tissue. We do send that out on occasion if something was seen in the tissue. We understand it may not be perfect, but if that's all that we have to go with, and then we start turning toward some of our specialized laboratories that have specialized PCR and different kinds of NGS sequencing assistance. And it's a group decision, and we try to do it in the most cost-effective and rapid manner as possible. But these patients can be very, very difficult at times, and so we have to go to those means.
Yes. And another important discussion is with Dr. Huang, and it appears to be about making some distinctions early on the difference between rejection findings and overlapping signs of infection, and how to take the next step in making the differential diagnostic testing done when that's in question.
Yeah, thank you. I think that's a very difficult question, and really that distinction is kind of the bane of our existence as pathologists. I mean, much of the time it is next to impossible to tell, and it is multidisciplinary. To Annalisa's comment in the chat, I think there are developments in kind of the blood-based biomarker tests, and not just blood-based, but potentially other kind of tissue or even fluid-based testing. I think much of it is still kind of in the research realm right now. I suspect that the clinical validation may be challenging because you still need to decide what's ground truth, and is this actually rejection or is it actually infection? So, interesting and potentially promising, but I suspect those may have more utility in let's say heart transplant than lung transplant, when infection of the lungs is something that's happening very often, and it's sometimes difficult to tell whether there's actually rejection or infection there. Yeah, Dr. Morgan, I see, has her
I
hand
was
up.
just going to say that there's a lot of biomarker movement for helping with the diagnosis of sepsis. And that might come about before some of the issues that you're discussing, which are a lot more difficult to distinguish than if a patient has sepsis or not.
No, I think there are, like, and with sepsis, I mean, sort of circulating nucleic acid based metagenomics may be of interest, for instance, but one would assume that the patient would be pretty sick if you're picking up organisms like that in circulating cell-free DNA.
I think we could probably talk for many hours on these topics. I do want to just mention, and maybe we can get back to a few more discussion points, but the next ISHLT webinar, I'm just going to announce here, is tomorrow morning. It's about CMV, and it's about the complex management decisions that we encounter with CMV. And that is tomorrow, 10 a.m. Eastern Standard Time. And there's a link that can be available to join that. I would just like to ask the group about, these cases in which I'll point out the cardiac case, where a patient refused what could have been a more rapid diagnostic test, which was an endomyocardial biopsy. And there's a little unclarity about the tempo of how the case unfolded, about the timeline, but this patient was at very high risk for invasive fungal infection. Although she was well beyond a time frame when one might have prophylaxed her, and she was certainly pregnant in that interim and then postpartum, so may not have been a logical choice. But would any of the discussants want to offer any recommendations on earlier testing that might have been performed in lieu of an endomyocardial biopsy?
I mean, I think from what I gathered from the clinical team, that she did have I guess like blood cultures and sputum cultures at a time as a workup to see if there was any infection, and they were all negative. But in terms of other diagnostic methods, I'm not sure, but they did what they could do at the time, I think, and it was just all negative. Yeah.
Sure, Dr. Morgan, in the setting of potential fungal diagnosis in other.
I can tell you probably in our institution, they would have probably ordered a liquid biopsy and did the test on EDA collected plasma to see if there's anything circulating in the blood. I'm not saying that that's going to be 100% beneficial, but I think that would have probably been their next step. And we would have looked very closely at the tissues and different kinds of specimens that we received for the antifungal cultures. Was there antifungal therapy prior to us trying to do them? Did we really do the best possible cultures? And then of course compare to pathology. So I think that would have been our approach. I think the one thing I might say is there's a lot of questions to me about how we get together with pathology and do we actually share information and things. I wish we did more of it, but we do share. But the other thing that I'm very fortunate with at Cedars is we share a lot with our infectious disease people who are always on these transplant cases. So I think it ends up not just being micro and pathology or micro and ID, it ends up being the three groups getting together to discuss. And a lot of times we come into our best conclusions when the three of us, ID, path, and micro get together to discuss things.
A team sport.
Yeah, I think we are at the end of our webinar. I would like to thank you all presenters, all attendees for the wonderful webinar, great discussion, and we hope we'll see you next time. And also thank you ISHLT providing us this format to share our knowledge, our experiences with others. Thank you very much, everybody.